Good afternoon. Thank you so much for joining us today to listen and ask questions about Canada's primary healthcare system that seems to be on the brink of collapse. The numbers are really quite shocking. Nearly 1 in 4 British Columbians can't find a family doctor, and they're part of the group of an estimated 4.6 million Canadians who can't find a family doctor. And it gets worse than that. We recently did a Leger survey in British Columbia. It was done by Postmedia, and it found that nearly a third of British Columbians who don't have a family doctor or a primary care provider have actually given up hope. They don't think they're going to be able to find a doctor. They don't think they're going to be able to get one, and they aren't even looking anymore, many of them. Because of that, or perhaps as a corollary of that, 55% of the people told the pollster that they would like to have more foreign doctors brought in, foreign trained professionals. But the survey found that everybody wants better healthcare. There's no debate about that. 42% of the people believe that doctors are underpaid. But here's the but. A third don't want to pay more for it. And 1 in 5 say they certainly do not want to pay extra fees. So how are we going to fix this? Joining me to talk about this today and answer your questions are the President of Doctors of British Columbia, Ramneek Dosanjh, and President-elect Josh Greggain. Dr. Dosanjh received her medical degree in England, did a residency in the United States before moving to Delta. She is a family doctor and a hospitalist, and if you don't know what a hospitalist is, I had to look it up, so I'll let you know. Hospitalists are specialists who look after the orphaned patients who show up in hospital and don't have a family doctor. Dr. Greggain received his medical degree from the University of Calgary. He did his family medicine residency in Chilliwack, and then he moved to Hope. In Hope, he worked at a medical clinic and also in the hospital, and he has recently relocated to Victoria, which will be good news for all those people in Victoria who don't have family doctors. And what we've learned is that Victoria is one of the most underserved when it comes to family doctors. So before we start, I have to do a little bit of housekeeping. Here's what you need to know if you have a question or a comment. On the right-hand side of your screen, you'll see a Q&A field. Click Ask a Question, type in your question or comment, and then push Send. You'll note that you will also be able to post comments and respond to other people who were on that chat. So, Dr. Dosanjh, we're going to start with you. You had a meeting yesterday. You and some of the others from the Doctors of B.C. met with the Premier, John Horgan, and Health Minister Adrian Dix. And following that meeting, the Premier put out a statement committing to work with doctors toward what he called transformational change. But one of the things that the Premier vowed would not happen, and one path his government will not take, is privatization. So, Dr. Dosanjh, is it time to put doctors on salaries and get rid of the fee-for-service care, or are there other things that would form this kind of transformational change that we all think is so necessary?
Well, thank you for your question, Daphne. Before I address the question, I just want to address everyone and acknowledge that I'm speaking to all of you from the unceded territory of the Tsawwassen, First Nation, and Musqueam Nations. So before I begin my conversation, I do want to pay greatest respect to their territories and acknowledge the land which I am speaking to all of you today. And to answer your question, we had a very frank, honest, and robust discussion with both our Premier and our Minister, our Health Minister, and we were able to engage in a fulsome dialogue about our primary care crisis. And when you're asking about the fee-for-service and alternative payment models, what we really need to understand are the needs of our patients, the needs of our communities, and the needs of our family doctors providing 90% of the primary care in this province. So that being said, we need to be flexible. I think we've had gaps in our antiquated model, which has been traditionally fee-for-service, but we have many physicians that have made it work. And we are not looking to change something that is actually keeping family doctors' clinics open. What we are hopeful about is collaborating and creating new funding models and new compensation models, but really to think if we can fund critical infrastructure, which we need, our family doctor clinics, to have the opportunity to stay open and address that rising cost of business that's really plaguing so many of our physician colleagues on the ground and keeping them away from practicing the care that they want to deliver to our patients. This is all about patients, and I want people to understand that doctors went to medicine to care for our patients. We all want to be able to provide the best healthcare that we can, and we need our government partners to support that.
Dr. Greggain, would you like to add something to that? I know that you recently posted on the Doctors of B.C. website about the difficulties that young doctors have when they're starting into practice. So can you talk a little bit about why doctors maybe don't want to be a family doctor?
Thanks, Daphne. That's a complicated and complex question, as you can appreciate. And I will give credit to my colleague and President, Dr. Dosanjh, for the idea of sharing the stories of what it is to be a family physician and just a physician across British Columbia. We've leaned on the idea of humans of New York, and we've called this program the Doctors of B.C. And so, Daphne, I did share pretty openly about the struggles of being a young physician and trying to make ends meet while having 2 children through medical school and residency. And so, what the purpose of that was to be a bit more vulnerable as far as what the plight of our family physicians are. And I think that ties directly to the next question you asked me, which was really around, the hardships of medical school are legitimate. The financial strain is significant. And so one of the appeals to do a specialization or other things is different resource management. And so what we're really hoping to do as the meeting yesterday and a true collaborative spirit continues, is a reinvestment or further investment into primary care, so that, and I will use some language, Daphne, that we've used at the divisions of family practice over the years, which we will make family medicine both irresistible and voluntary, creating time and space for people to come into the sphere, do the kind of medicine that we know is so life-giving for patients, but also then life-giving for our providers.
I had an emailed question from a family physician, actually, who isn't able to join us today, but he said to me that that when he went to medical school, that most of the people who graduated, 50% of his class, became family doctors, and he graduated in 1984. He said that only about 1/3 of the graduates now are ending up in family practice. And so he's wondering, his question is, are we simply not providing, are we providing too many residency spots for other specialists? Are we streaming them into these other specialties for other reasons? And are there enough family residencies so that we can have enough family doctors in this province? Dr. Dosanjh or Dr. Greggain, whoever would like to take that question.
I'm happy to jump in if you like, Daphne. And so over the years, and a credit to UBC, they have expanded the family medicine residency programs and specifically opened up programs in places like Kamloops and Kelowna and Terrace, Nanaimo, et cetera. And so I don't think it's a lack of spots. I believe it's the lack of the appeal. And so when the pay differential is significant between specialists, and I'll be very frank, Daphne, it's not even just about the choosing your residency between family medicine and a specialty. It's also then once you become your 2-year residency, do you actually come and provide longitudinal family practice? And there are competing interests in other things like hospitalists and palliative care and emergency medicine, which are so valuable and critical to the function of the system, but again, take away from that longitudinal relationship we know is so critical. And so I acknowledge that in 1984, before there was a true family practice residency, it was a different era, that the challenges then were different than what they are now in 2022. And we're trying to be adaptable and forward thinking to not only help the current difficulties, but also then look towards the future to make this the unequivocal best profession out there.
Would you like to add anything, Dr. Dosanjh?
Sure. I just want to reiterate that what we are seeing, the patterns, I think the initial CARMS first match this year, we saw.
And just to explain, a CARMS match, it's the national body that takes graduates and matches them with a residency anywhere across the country.
Correct. And we saw over 220 spots that were initially vacant. And that speaks volumes of what we're seeing across the nation. And that's the reduced uptake of family medicine and a lot of things what Dr. Greggain has so eloquently described. I think we need to understand that we need to make this palatable to all of our residents that are going through medicine, but we also need to understand the constructs in which we are and the confines in which we find ourselves. And yes, it is about recruitment, but it's also about retention. I think right now what we're facing is a crisis, and we need to be able to retain the family doctors, 3,200 of them that are providing longitudinal care in this province immediately. That's why the sense of urgency. But I am hopeful that we have got through a pandemic and we have been managing many crises. But I think if we can be trusted as physicians that truly have our patients' best interest in their care, patients show up at our door because they trust us. And we do have other avenues of medicine that, yes, they've taken us away, but I do not think it's just the monetary compensation. I really do think, even from my own experience, I love my longitudinal practice, but I couldn't keep the lights on. I could not meet the overhead demands. And yes, people will say there's some gender inequities in how we practice. I do like to provide longer patient visits. And I think most family physicians, if they were paid based on their time and their ability to be able to spend more time with their patients, that's another way to think, because a lot of us want to do that type of care that keeps the patient healthy.
Well, can you just explain this a little bit more about the costs? So my understanding is that there's a variable fee for one visit, an office visit, depending on age. So let's just generally say it's $32. So of that $32, that's for is that for a 15-minute visit? And then of that $32, if you're running a private practice, how much of that money do you actually get?
Dr. Greggain, you want to from your own clinic and see how expensive it is to run?
More than happy to, Dr. Dosanjh. So over the last 15 years, I have owned a clinic, I have run a clinic, I have worked in Indigenous clinics, I've had a whole series of opportunities about what it looks like. And so this is what we know from as we survey our colleagues. It's a few years ago now, but we estimate between 30 and 35% of all of gross income into the family physician office goes out to pay staff. And this is what we speak of when we say trying to run a business. And so my staff, I have a group of physicians that work together. And so I have to pay the rent, the lights, my staff, my office staff. If I want to have a nurse, then I have to pay her or him. I need to create opportunities for the team-based care phenomenon, again, based on this singular fee code. And so to contrast some of the acute care facilities or schools, the schools are built, the hospitals are built, and then the people who work there aren't paying for the building or the structure. And so that's really the narrative we're saying as far as a family physician, I'm trying to, out of that $32 or 30 some odd dollars, trying to get enough resource for myself to make sure, again, my family, has a place to live and a food on the table, but also then trying to support the small business and the livelihood of my staff in and around me. And so the metrics for fee for service produces volume. And so if you want to make sure the lights stay on, you have to see more and more patients, which limits their time with the provider, leading to arguably patient dissatisfaction. And so the system needs to evolve, as Dr. Dosanjh said, so we get what we pay for, and we have an opportunity to not only provide the kind of care, the quantity of care, but really the quality of care that patients deserve, and we as family physicians want to provide.
One of the issues that's come up and been quite controversial, given the comments of the health minister, is what about nurse practitioners? I mean, if we don't have enough doctors, why don't we have nurse practitioners? And my understanding, though, is that nurse practitioners are paid in a much different way. So the way that they're paid allows them to spend more time with the patient. So can you explain that so we can understand better why you may not be so keen on having nurse practitioners doing a similar job to you, without obviously as much training, but a similar job to you, and maybe being an allied worker in the primary care field?
And so with Dr. Dosanjh's permission, I'll take that question as well, only because I have hired nurse practitioners. I have worked alongside nurse practitioners. Some of the earliest nurse practitioners in British Columbia worked out of a community called Advocacy, for which I was able to work alongside starting in 2006. And so I'm going to say this plainly and simply, Daphne, which is there is plenty of work in primary care to go around, and the nurse practitioners have a role. It is not an equivalent role to family physicians. Family physicians are the foundational element to primary care, but there's lots of opportunity. What the privilege, and I tell this to my nurse practitioner colleagues, the privilege to be on salary gives some more flexibility to try and create time and space for individual patients. And so in my home community of Hope, where I practiced for many years, one of our nurse practitioners focused really on mental health and youth. One of our nurse practitioners focused really on the residential long-term care facilities, and one really focused then again on geriatrics. And so it creates a flexibility and a time with patients that if you have to see a certain number of patients a day in the fee-for-service model, it is not equal. They are not apples to apples, they are oranges to oranges. And one of the opportunities may be for physicians to work on a salary model, and those opportunities are in evolution, but again, they are not apples to apples at this current state.
Okay, if you don't, well, let's move to a couple of, we have some questions, and one of the questions is that, well, let me just read you the question. I found a family doctor that, well, I was single and still living in Vancouver, but it required being on a wait list for some time before I was accepted as a patient. I now have a family of my own and live outside the city and have struggled to find a family doctor I can transfer to. There are no open wait lists. I can even put my name down. There are no open wait lists that I could even put my name down for. Is there any way to implement some kind of wait list system, either provincially or by each office? Is that a possibility?
I think, Daphne, what we know about this wait list is that divisions of family practice for many of our communities did offer a service. And at one time, the College of Physicians of Surgeons of British Columbia also did. I think what we're finding ourselves is the fact that this is a crisis is sometimes an understatement, because we know minute to minute we have physicians that are exiting practice. And we would love, I feel that patient, I have many patients and families, especially even my parts of my own extended family that have been orphaned and do not have a family physician to see them or their family. So this is why there's need for urgencies. And this is why we're really working with our partners to really allow our patients some breathing room. We need to be able to create structures and that infrastructural funding. And when I'll go back to your point, Daphne, about nurse practitioners, the other privilege that my colleagues have, who I have worked also alongside many nurse practitioners and have many friends that are nurse practitioners, have a great deal of respect of what they do in their profession. And I agree with Josh when he says there's enough work for all of us. I do want everyone to understand, same way that we are paid in acute medicine, nurse practitioners' settings and clinics are paid for. That infrastructure is already taken care of by the government. So that's why they have more time to spend with their patients. Please, I would urge our partners to also consider that overhead funding for our family physicians on the ground, because we cannot keep our clinics and our lights on. And if we were able to keep them on, we could open so many more clinics, and an access issue, issue would be yesterday.
Dr. Dosanjh, your feed is cutting out a little bit, so I'm going to ask the next question to Dr. Greggain. The questioner is saying, what is then how do I find a family doctor? I mean, the first question that I read, somebody emailed me and said, you know, I had a family doctor. My doctor, who I loved, retired, and he couldn't find a replacement. So the replacement doctor is only working part-time, and this woman who is 60 years old and very healthy, she got kicked out of the practice. She was too healthy. They only took the sickest of them. So what do patients do? Is there any advice you can give to all these people who are frankly terrified of not having a doctor?
And again, thanks for that question, Daphne. I think that's the root of the trouble we're having, which is there just simply isn't enough primary care, including family physicians, to fill all the spaces that we need. And so there is not a singular answer. I wish I could give you one piece of advice to say, oh, if you call this magic number that we all have access to, suddenly there'll be more family physicians to appear. The reality is, and this is my earlier statement, it's going to take systemic change. It's going to take all of us involved and invested in how we're going to do this. And it's going to take a collaborative spirit that historically may not have been there because of the lack of a crisis, but now we're in a place where we need everyone to work together. And so that is an opportunity for family physicians, for Doctors of B.C, for the government, for nurse practitioners, for divisions of family practice, for our specialist colleagues to really try and solve this, conundrum in a significant way. And so there is
it's fine to say collaborative and all of that, but collaborative meaning what? I mean, we desperately need doctors. No amount of collaborating is going to magically come up with these doctors. So what are we going to do in the short term for all these people who don't have a doctor?
So right now, Daphne, what I would like to say to that is the reason I'm going to stand alongside all of our patients that are championing this advocacy and need for change tomorrow at the lawn of the legislature, in front of our house, in front of our premier and our health minister, alongside our patients. We are just as desperate. We want our patients. We know that the days that they don't get in with access and attachment to a family doctor, that causes mortality. We know that clock is ticking, and that's why I met with them yesterday to profess this urgency. It's not an alarm. It really is an opportunity for us to come together and to give our patients a very tangible solution we can actually make a difference. We know we can make a difference overnight. Just look at and trust us on how we did with the pandemic response. We were able to develop a vaccine in record time, and this is physicians and collaborators around the world working. And I think in this province, we've done so well with under our PHO and the mandates. We've got more than 90% of people that were vaccinated, and we were able to keep our numbers down. So I do think that they need to trust patients and listen to their voices, because we will be standing shoulder to shoulder with them to make everyone understand. We want the ability to be able to keep our clinics open and to serve our patients. And we know how to do this best. So please allow us the ability to influence alongside our patient partners in this transformational change.
But that transformational change, how do we get doctors and how do we get people or nurse practitioners? How do we get them now? Are we going? Do we need to boost? I mean, even if we boost spending to medical schools, we're not going to get those doctors within a short period of time.
I think one of the immediate asks is to immediately help those physicians keep their doors open and provide an opportunity for the family doctors. We have over 6,100 family doctors in this province, including myself, that are not doing full service medicine right now. And we have 3,200 that have kept their doors open. So we need to incentivize immediately, take their infrastructure funding, allow them to cover their cost of overhead, and give them some sort of timely response and able to keep their lights on for the next few years, and to enable access and attachment immediately for our patients. That's what we're asking for. That's not the fix all. We know it's a long-term solution. We know that not everything rests in the urgent and immediate solutions, but we know that we need something now, and that is to be able to take over that overhead cost, pay us. If we think we have the critical infrastructure funding as our colleagues of nurse practitioners, they walk in, they're able to do their work, and they don't have to think about paying their staff or using the money to pay their utility and to keep afloat. We are asking, that's one of our asks. And the other ask is that we've got other tables of collaboration, and we talk about collaboration and partners, Daphne. The public needs to know that we have the GPSC that was created as a General Practice Service Commission, and where it's a shared table with our Ministry of Health, and that's with our doctor partners. And they have the ability, like has been mentioned, is through the divisions of family practice. We have great avenues where we've got champion physicians on the ground advocating for each of their community needs. We need to encourage more robust, influential partnership at those levels, because we can immediately absorb that access and attachment if given the resource and the funding.
Is there any appetite amongst doctors in British Columbia to give up fee-for-service and simply go on to a salaried model, with the government running the clinics, paying for all of the overhead, so that frees you to do what you know how to do best, which is look after people? Is there an appetite for that?
Absolutely. I mean, I hear from so many members that are desperate to stay in their practice and are looking for an opportunity to do things differently. I know there are many of my colleagues that say, I don't want things to change. I only have a few years before I retire. We're not looking to change it for them. But for those people that have the appetite, and I believe it's pretty voracious when I'm listening to a lot of my colleagues, is you take care of all of that management and I will do my doctoring, what I do best.
Dr. Greggain, do you agree with that?
So I was going to add to that simply to say that many of our rural communities are on we call APP or alternate payment, programs. Some are contracted, some are salary, and some of those have been expanded over the pandemic. And so really it's that decision tree between autonomy and independence versus resource management. And so that is not a singular answer for a singular person, but again, creating adaptive and collaborative solutions to a complex problem is the only way we're going to do that. I'm going to circle back, Daphne, to again, you asked about how we're going to collaborate and sort of fix this problem. And so I'll reflect that our new family practice residents are graduating July 1st. And so they are all watching carefully to see what transpires over the coming weeks, to see if they are then going to opt into a longitudinal family practice on July 2nd, or whether they're going to opt into other options, including surgical assist and palliative care and hospitalist. And again, I acknowledge that we need all of those things, but if we graduated all of our family practice residents into family practice on July 2nd, we would be in a better place. The second thing is, again, and I've met with several international physicians who are living in Canada right now who are not working in their field for a variety of reasons. And there have been solutions or programs, including the PRA B.C, trying to incorporate those physicians trained in other countries into our country and our medical system. And yet it's not an easy road and it's not an easy pathway. And so again, there are a multitude of options. What we're trying to ensure is we're working together to make this a better situation for, again, as Dr. Dosanjh said, patients and providers and the government, and trying find that Venn diagram of a solution that will make the most sense for the most people, recognizing it's not the same in every part of this province.
One of the people has posted a question asking, until there are permanent solutions to the doctor shortage, is it possible to have a similar system to a walk-in clinic, but with appointments available? Is that possible? Any thoughts?
Anything is possible, Daphne. Go ahead, Dr. Dosanjh.
I think we're open to innovative ideas, but I do understand how people feel that they need immediate access. I actually truly believe that if we can do both, if we can provide immediate access and attachment, it is better for the patient's well-being and long-term trajectory. We know that the patients that have a family doctor, and that's not in our own province, that's a world healthcare system recognition, is that when patients are attached to family doctors, they have better lives, they have better outcomes, they live longer. And why would we not set it up to succeed from the beginning? When we know if we could have an immediate action that would guarantee access and attachment for our patients, that's what we want to advocate for. We're not taking away from walk-in clinics and the urgent care centers. I understand there's an access, and I know that our acute care settings or in emergency rooms are in an uproar right now because there are such long wait times. But true time to decrease those wait times for the 2 to 5 year trajectory, the 5 to 10 year trajectory, it needs to be rooted in primary care system reform. And that is what we're asking for. True attachment and access. We've got so many physicians that are ready. And like you said, Daphne, they have an appetite. They are ready to put the work and commitment here, but we need our government to be able to be with us on this.
You're talking about collaborating, and I know that Dr. Dosanjh, you are a foreign trained doctor. I've written a lot about foreign trained doctors and the hurdles that they have to go through, the numbers that we're told of foreign trained doctors who are living in Canada who are not able to practice in Canada. Is there something, are you and other doctors, are you going to be advocating for those doctors to
Absolutely.
get qualified?
Great. The Doctors of BC has been part of this advocacy from the beginning, and we have been trying to meet with our College of Physicians and Surgeons, who is the governing and the regulatory body for physicians. And even in our conversation yesterday, we did hear some of that from our government partners, that there are been pressures because, as you know, yes, I was trained abroad, and to come back, you have to write all of your exams. You have to jump all these hoops and all these hurdles, but you know that your clinical skills, I mean, I did my training in the US and I did a 3-year residency. And I felt a little overqualified at times to come back into the setting, but the hoops in order to get to the practice setting is so difficult. And I've heard from so many of my American colleagues that are willing to come up and help. And so we also need to address that there's 3,000 other physicians here, and we've got incoming residency class that's here. What can we offer them now in order to set up and help our patients?
But what I mean, it's perhaps unfair to ask you this, because both of you are young doctors, but in the past there has been so
Thank
much,
you.
but there's been so much resistance to both getting rid of the fee-for-service model and working collaboratively with allied healthcare workers, including dietitians and nurse practitioners. And there's been really strong resistance to in any way changing the accreditation. Is this a generational thing?
I don't believe this is just a generational thing, because I know so many physicians, my retired colleagues who I have very frequent conversations with, wish it would have been different. When they look back in hindsight, they wish that the opportunities were different, but they also recognize the landscape in which we're in. We have an evolving medical landscape. We used to admit patients for pneumonia. We used to take care of blood clots inpatient. We used to have C-section women stay for 2 weeks in the hospital. We are sending people home sometimes same day and next day. We have come to a climate where we have medical complexities that have increased, but the funding and the infrastructure for primary care has not changed, especially going to the clinic directly in order to have physicians be able to set up their practice. So that's unfair. That I don't believe that fee-for-service was even given a fair chance, to be honest. But I do believe that the landscape that we're in now definitely needs evolution. We need a modernization of our fee payment schedule. We need alternative payment models. We need a menu of options, because there are definitely different doctors need different ways of being paid and remunerated, but different doctors work in different ways as well. There are many of us that want to spend as much time as we can with our patients, and there are some people that are a lot more effective and efficient. And I want to be able to speak that while there was a lot of pushback, culture change is also happening. We have to look at our workforce. Now we have 54% females that are entering our workforce, and we have to be relevant with the times. The gender inequities, we won't get started today, but we really want to ensure that people know that women's health and children's health and mental health, there's a pay disparity. Okay, we have many places that we could assert pressure to make change. And I just want to make sure that people know that doctors are here for their patients. We're committed to them, but we're also committed to the solutions. There's many pockets of solutions that have been drawn out with physicians. They've had innovative ideas because they've had to work outside the box, many of which I know Dr. Greggain, I'll let him speak to the RCC and the evolution of rural health, because if anybody knows uncertainty and scarcity, it's our rural remote communities. There are people in Indigenous lands that don't even have access. So let's lean on our partners that have done it well and use that information to frame our now. And what we know is that we need a solution, an immediate solution now.
And I'll jump in there, Daphne, just because I feel like Dr. Dosanjh put me on the spot, but I'm happy to take that spotlight and acknowledge that our most adaptable, our most resilient, our most innovative providers and communities and patients are the ones that are most rural and most remote. And so the COVID pandemic has created opportunities for some of those innovations to flourish. And so I belong to the RTVS, so the real-time virtual support, providing virtual care to our remote and rural Indigenous communities, emergency rooms, alongside a slew of pediatricians, family physicians, emergency room physicians, intensivists, dermatologists, etc. And so when we look at what the solutions are not unitary. The solutions are a multitude of different ones. And looking at, again, as an appreciative inquiry perspective on what's going well and how we're going to do it and how we're going to fund it, and sit around the table as the RCC, or the Rural Coordination Center of BC, has done for eons, is the way that we lean into the solutions that are going to meet the vast majority of needs. It is clear, Daphne, we're never going to meet 1,000% of the needs, but trying to create a time and a space and a process for how we're going to do that and how we're going to do that collaboratively is really the secret sauce to solving this problem.
One of the things that you just touched on, Dr. Greggain, is the changes that happened during COVID. I think amongst the most stunning ones for many of us was telemedicine. And what telemedicine, I mean, I had a doc, I had a couple of appointments actually using telemedicine, which I think many of us who've had telemedicine visits have had mixed results. The idea that you actually just talk on the phone to somebody, I mean, it's really not what we think of as medicine. We think of the hands-onness of medicine. And what we also saw during COVID was this whole corporatization. All of these companies jumping in and their shares went up, and everybody's saying, and certainly in the United States, let's invest in telemedicine. How much do either or both of you think that telemedicine is part of a solution, particularly for people in rural areas where, again, they have unique problems? Some of them don't have the internet, or at least high-speed internet. Is this part of the solution, but is it not a panacea?
And Daphne, I'll jump in again with my rural background and say that is the absolute correct statement, which is it is a part of the solution. It is a part of the solution to help amplify the connection and relationship. A standalone or corporate model where you just sort of appear out of nowhere is not what patients or providers want. However, having virtual care alongside your longitudinal relationship-based family practice is a paramount. And I appreciate, Daphne, you and maybe some of your colleagues and friends have had mixed experiences. The providers have had the same. It's been a mixed bag of opportunity, and yet some of my patients have absolutely relished in it. And I'll say specifically in and around mental health. Some of our younger patients have really valued the opportunity to speak on the phone, who don't have to then enter into an exam room or sit in a small town where everyone knows where you're going. And so I believe wholeheartedly virtual care is part of our future. And again, the process and the execution and the availability really needs to be fundamentally based in primary care, not in corporate care, not in teleporting somewhere else, but creating time and space for people to build connections and get the care that they need. And then when they need a physical exam, whether that be a shoulder injection or a knee exam, or sometimes just an opportunity to connect with your provider, then that's really what has to happen in the physical space.
Okay, we're running short of time, and we have a number of questions, so let's zip through a couple of them. Is there any interest in providing private care since there is inadequate public care? Are doctors interested in privatization? Dr. Dosanjh, you're the president.
Right. I think what we need to understand is that we need to adhere to our Canada Health Act, and that's what I would tell our patients. Like you mentioned about virtual health and telemedicine and corporate world coming into this entity, what we need to go back is to make sure that we adhere to our Canada Health Act. We were built for care for everybody. And I think we need to acknowledge that. There are parts of our system that are operating in private entities, and I will acknowledge that. We've got our WCB and ICBC and private centers that they do expedite certain surgeries or certain interventions. So just so our readers are well aware, I think, of this process. But I believe that if we build a system based for our most marginalized population, which is some of our rural and remote communities where Indigenous people, we don't even have access to them. If we can really, truly make a concerted effort to attachment and access, there will be no need for another duplicate system. I have worked in a US system. I know the duality, and I know that there are some wins. And of course, in a crisis moment, we look to anything that will help us because we're pulling at straws and we're pulling at things that we are telling you we have a very real, tangible solution for all family doctors in this province and for our commitment to our patients. We just need the government to trust us in rolling this out and advising them, because what they need to know and our patients need to know is that we are advocating for our patients. They trust us. We know them. We know their health patterns. We know the communities. We know their families. So please allow us the ability and the capacity to not only inform change, influence change, but transform change, because we have had avenues like the divisions in which we can do that. And so before we look to other aspects of care, let's do Canada proud and this province proud. We are a first world country in the 21st century. It is time that we speak and we act like it. Our patients are suffering and do not deserve this crisis, and our providers are burnt out and in the highest rates of moral distress than we've ever seen. So before we look to alternative solutions, let's recreate the one we have here.
But one of the questioners, I think quite rightly, says, but how long if we just keep it? Can we do this without continuing to add money? I mean, the Leger survey said most people don't want to pay more money. They think doctors are underpaid, but where are we going to get the money from? Healthcare is already a huge part of the budget. How do we do this within a budget without having it take up everything we have, so we don't even have roads left anymore?
Right. So I've got a few answers to that, Daphne. I think we have to be innovative. We pivoted on a dime for COVID. You're talking about virtual care fees. Within 48 hours, we had our virtual care fees funded. We took immediate action in a crisis. In a pandemic, yes, we have a deficit. There are also other opportunities. I do believe we need new monies, but there are also opportunities such as decreasing the lack of administrative burden. That costs us nothing, but the government could make that happen very quickly, because those forms that you go to your doctor with that take us half an hour to 45 minutes to fill out, which are, in my personal opinion, not necessary. And that's taking away from patient direct care. Yes, we could employ our allied healthcare professionals that have some clinical background, our nursing staff, and maybe our nurse practitioners to help shoulder that burden. Fantastic. That's how we can work in teams. But take away the stuff that doesn't cost money right now as well. Take away the administrative burden. Give us a little bit of solutions with the locums or after hours coverage. So some of our colleagues that have been working 24/7 or 6 to 7 days a week for the last 2.5 years to keep the doors on, even in the emergency department, let's give them a little bit of a break. We need to be able to pivot and innovate. And we've got many innovators here, and we know that we can find solutions. So there's hope in trusting us in the immediate.
But you're still saying we need to bring in locums. We need people to give them a break. Where are we going to get those people from? I mean, it's not like there are a bunch of doctors sitting on the sidelines other than the foreign trained doctors. So aside from getting them moving, I mean, we did see, as you said, there were lots of pivots. There were physician assistants, the associate physicians, or what I think was the name that the college was given the right to create that position. There hasn't been a single one hired. And the other thing that strikes me about that position is what we're saying is that if you're a foreign trained doctor, we're not going to let you be a real doctor. You're only going to be an associate doctor, that somehow that you then won't have to be paid as much. I mean, where are we going to get the doctors from? Are we going to go recruiting in other countries? And we know that there's a healthcare shortage everywhere in the world. Where are we going to get them from?
Definitely, we have, again, I'll reiterate, we have between 31 to 3,200 physicians that are providing longitudinal care in this province. We have well over 6,000 physicians in this province alone. And let me tell you, there's a big appetite to be able to do primary care and family medicine if the setting is right. Many of them, including myself, walked away from our private practice or clinic because we could not make the business case work. And the burden became way too hard. And we took personal sacrifice, and some of us personal health sacrifices because of it. But if they gave us something that meets our needs, then you have us. There are many of us that are willing to work here.
But if you're already working, then does that not then just move people out of the hospital system back to private, into their private offices? Then how do we backfill that?
No, there's many. This is the thing. I know many physicians that are choosing or have made life decisions to work less full-time equivalents because the system does not make any sense for them. They can't provide the kind of care they want to. But if you pay them and incentivize them to be able to provide the first world type of care that our patients deserve, absolutely. And I think we don't talk about our values. And I think a lot of this is what's happened is the erosion of our values. I think when we have this discord and dissonance within ourselves that what care we're providing, many of us don't even want to work in certain settings that are just, transactional in some settings, because we truly believe in attachment. And you're right, as a hospitalist, initially I was the GP in the hospital that they became into this hospitalist program because of the orphan patients. And these were the unattached patients, but these were my colleagues' patients. These were all the family doctors that had been trying tirelessly to do this work. But again, at that time, the government was not responsive into the needs.
So are you saying that we actually have enough doctors here if we could just get them all working?
I truly believe we have plenty of doctors that be willing to contribute, and we could leverage our allied healthcare professionals. And also, Daphne, that we work on our college and our influence to be able to and allow our foreign trained medical doctors to be given that opportunity to practice.
I'm going to jump in there, Daphne, and I'm going to go back to this statement, which is going to take all of us. And so it's going to take decanting what the family doctors are currently doing alongside an investment of resources so it becomes more appealing. That's going to take some system change in our acute care facilities. It's going to have nurse practitioners and allied health be a part of the team to try and decant that. And it needs to then make the family medicine residents, who are again graduating in 6 to 8 weeks, having a peer about what that's going to look like. And so it's not a singular solution. We need to leverage what we have currently in the short term. We need to look at what the medium term is going to be as far as what's the future of primary care, and ultimately look towards the future to ensure that what's fundamental in Canada is the opportunity for you to get the healthcare that we're so fiercely proud of.
One of the people has, Denny has posted, so you three could solve the problem if you were given the opportunity. How can we get the government and the College of Physicians on Surgeons on board?
I wish it was that easy. It lies in our membership, and I do truly believe that Doctors of B.C. is an organization with its members' best interests at heart. We are nearing 16,000 members, and we are a voluntary organization that our members happily belong to. And I do believe the answers are within us. And we have been speaking about what it would take. We just need a little bit of trust and a little bit of courageous action. And I promise you, we are wholeheartedly committed to our patients every day. If it's a specialist or an expert in family medicine, as our family doctors are, we need to trust one another, and that we are here for our patients. We want the best outcomes and trust as an organization. And it's time that we understand our patients are also fearlessly advocating for us. And we haven't seen this large scale activism in some time. So we're really hopeful that this outward cry of the reality of how painful it is on the ground, without access and without attachment and without the working conditions that are palatable and sufficient to be able to provide this care, we really are hoping that this collaborative communication and dialogue with this government results in some immediate actions, because every British Columbian
But you've been negotiating. Your contract has been up for several months now, and we haven't seen any movement other than the Premier's statement, which is we're all trying to get there. But I mean, at what point, you talked about the activism, at what point are you, Dr. Greggain and Dr. Dosanjh, what point are you going to say to your members, we're going to have to pull our services if we're going to make this happen? We haven't had a doctor's strike for a long time. Is that something that the doctors would be willing to do?
Well, I don't want to speak for all the doctors, but I am in a position right now that they entrust myself and our board and to steer our profession in a very trying time. And the meeting with the minister yesterday, traditionally they're done with the president and staff. And I took our board chair, Dr. Adam Thompson, alongside with me, because I understand the importance in the power of all of us. It does not lie in one person. And please don't ever think that it lies in any one of just one of us. It lies in our patients and their advocacy and their loud voices, and also in the physicians that understand, even our specialist colleagues. They really understand, because general surgeons don't want to be providing birth control, or they don't want to be dealing with complex comorbidity, juggling many specialist care at the same time of their subspecialty. I'm hearing that every day and day in and day out. And what we need to recognize is that doctors will do what it takes, because right now there's so many that are leaving. And what I worry about, Daphne, is the despondence. You know, we can use our anguish and come out to rally, but what I'm really truly feeling is the sentiment on the ground is the moral distress. After the pandemic, it has really fractured many of us, and not just physicians, but our allied healthcare professionals. We're seeing the human resource issue with our nursing colleagues. We've got medical office assistants that are traumatized from the pandemic. And we've got a great deal of distress with so many of our partners, both in the hospital setting and clinic setting. So we need to recognize the climate. This is different than ever before. And we need to really press upon our government, as they know from yesterday's meeting, that we are truly meaning business, because it is our patients and their patients that we're failing. Because if we do not do something with immediate action, we could be failing our patients' healthcare and the healthcare of this province. And we may not see it today, we may not see it tomorrow, but the next generation will definitely be paying the price for it. And our baby boomers and our aging population will definitely be paying a price for it. So let's fix it now. We know we have some real great solutions that we could offer that would be appeasing our family physicians on the ground and our patient partners.
Dr. Greggain, would you like to add anything to that?
Yeah, I just want to continue to affirm what Dr. Dosanjh said, which was, and I'll go back to what Denny said, which is, oh, the three of you seem to have solved this problem. And the principle there is conversation, and the principle there is collaboration. So again, I lift my hands to Dr. Dosanjh and Dr. Thompson and our acting CEO, Jim, who was there yesterday at that meeting, to really have a frank conversation about what we're going to do together. I also want to, again, commend Camille Curry, who's organized the rally on the lawn of the legislature tomorrow. And so your question, Daphne, are doctors prepared to strike? No, it distresses us greatly to go and remove any kind of service. We really are there to help and to heal. And at this juncture, and I think Churchill said, never let a crisis go to waste. And so this opportunity is for us to gather together as a unified patients and providers in a system that is struggling to create time and space for our colleagues, our friends, our family, and our patients that we care for so much to do something different. And so this is our chance to do something different under, again, the auspices that Dr. Dosanjh and I can't solve this problem alone. It's going to take each and every one of us. And tomorrow is a great opportunity to celebrate family physicians, as well as then stand unified to say, there's a future that we don't like where this is going, and we need to do it differently. And it's going to take all of us.
So we're getting close to running out of time. So I'm going to ask each of you, Dr. Dosanjh, if you could have three things happen, which would be the first? What would be your three top priorities with this government?
My three top priorities. The first one would have to be the immediacy and the urgency to address the overhead costs for so many of our physicians on the ground to keep their lights open. I am faced with so many members that and colleagues that have provided amazing care, and we are at risk of losing the ones we have currently in practice. And we already know we have a crisis. That might just be the demise of primary care fully. The second ask I have is a true collaborative commitment, which I do believe our government has interest in at this point, is to use our existing structures that we do have within our primary care networks and our divisions of family practice, and to ensure that physicians' voice is heard, that we are not collaborated at, but we are talked to and respected, because our opinions, we are the champions of our patients. And I think it's time that people recognize, as was so eloquently put before me, is that patients and providers together, and anchoring that we are standing here side by side. And we have, every time you come into our clinic or you come into the hospital and we are looking after you, that is our commitment to you. So trust us with that decision making as we are in the collaborative space.
Dr. Greggain.
So I'll
What do you
speak to these three things. And again, I realize money doesn't buy you happiness or love, Daphne. And so money isn't the end all be all, but I would ask for a commitment to three principles. And the first one is equity. And the first one is creating some space for family physicians in longitudinal practice to be at least on par with our other colleagues who are doing similar type things. And so that's a value proposition more than anything else. The second one is really breaking down barriers. And I realize that's a complicated statement because again, there's a multitude of barriers in hierarchical organizations about how things are supposed to go. And so when we sit together, as the three of us just have for the last hour, unbelievable opportunity for innovation and creativity. And the first one and the last one is really a commitment to humility. And so it's the fact that just because you've done something for a long time doesn't mean you've done it right. And so the humility both from us as physicians, from the patients, and from the government to say, we are at a precipice of family medicine and primary care, and let's like a really good hard look on what the next 1 month, 1 year, and decade is going to look like, and let's put our cards on the table. And I don't mean that in a proverbial sense, but actually at the table that we get to sit around.
Well, thank you very much, both of you, for taking the time to do this. And thank you for all of the people who provided questions and are engaged in this. I think we all realize that we are at a precipice. And I think that the more we understand what the problems are on all around, both for the government, for the doctors, and for the patients themselves, I think that working together we can hopefully find a solution, and hopefully that we can find that solution without having to have any job actions and withdrawal of services and so on. But again, thank you so much. And I would remind everybody that we will be posting this video. You will be able to see it on our website. And if you have any other questions for those who, please feel free to email me. It's dbramham@postmedia.com. And we will try and follow up. I will try and follow up so that any of the questions we didn't get to that in future we will come back either in paper or possibly online and do this again. So thank you all. And it was really, really great to have you. Thank you so much.
Thank you. Thank you for having us today.
And thank you for all the readers and listeners who witnessed today. And again, may we continue to do this collectively.